Diabetic macular edema, DME, is a common complication of diabetes mellitus, affecting the macula, the central portion of the retina. It is characterized by the accumulation of fluid within the macula, leading to impaired vision. This condition represents a significant burden for patients and healthcare systems worldwide, necessitating an in-depth understanding of its pathophysiology, diagnostic modalities, and treatment options. DME develops due to alterations in the blood-retinal barrier, leading to increased vascular permeability, capillary leakage, and subsequent accumulation of fluid within the macula. Chronic hyperglycemia and impaired metabolic pathways contribute to oxidative stress, inflammation, and dysfunction of retinal cells and glial cells, perpetuating the pathophysiological cascade. Several molecular pathways, including the involvement of vascular endothelial growth factor, VEGF, play a key role in the development and progression of DME. Accurate and timely diagnosis of DME is essential for effective management. Various diagnostic modalities are available, including optical coherence tomography, OCT, and fluorescein angiography, FA. OCT enables visualization of retinal layers and measurement of central macular thickness, allowing for the assessment of edema severity. FA provides valuable information about retinal vascular leakage and helps identify areas of non-perfusion. VEGF is a potent angiogenic factor that plays a crucial role in neovascularization and vascular permeability. In the context of DME, increased VEGF levels contribute to the breakdown of the blood-retinal barrier, promoting the accumulation of fluid within the macula. Understanding the role of VEGF and its signaling pathways is crucial for the development of targeted therapies to manage DME. Anti-VEGF agents are currently the cornerstone of DME treatment. These agents inhibit VEGF's action, reducing vascular permeability and neovascularization. They commonly exert their effects by binding to VEGF isoforms or their receptors, thereby blocking their downstream signaling pathways. Pharmacokinetic properties such as absorption, distribution, metabolism, and elimination vary among different anti-VEGF agents, influencing their dosing regimens and treatment outcomes. The development of evidence-based treatment guidelines for DME relies on rigorous clinical trials. These trials assess the efficacy, safety, and optimal dosing of anti-VEGF agents. Endpoints commonly evaluated include visual acuity improvement, central macular thickness reduction, and adverse events. By critically evaluating clinical trial data, healthcare professionals can make informed decisions regarding the most appropriate treatment options for DME. Several anti-VEGF agents have received regulatory approval for the treatment of DME. These include ranibizumab, aflibercept, and bevacizumab. Each agent has unique pharmacokinetic properties, dosing regimens, and safety profiles, enabling healthcare providers to tailor treatment plans according to individual patient needs. Intravitreal injections are the preferred route of administration for anti-VEGF agents in DME. These injections involve the direct delivery of medications into the vitreous cavity using aseptic techniques. Proper administration techniques, including pre-injection preparation, injection site selection, and monitoring for complications, are crucial for achieving optimal treatment outcomes and minimizing the risk of adverse events. Regular monitoring of DME patients receiving anti-VEGF therapy is essential to assess treatment response and adjust management strategies as needed. Monitoring tools include visual acuity assessment, optical coherence tomography, and fundus examination. Individualized treatment frequency and intervals are determined based on disease activity, response to therapy, and the patient's overall visual and anatomical outcomes. Although generally well tolerated, anti-VEGF agents can be associated with certain adverse effects. These may include ocular complications such as endophthalmitis, retinal detachment, and intraocular inflammation. Systemic adverse events are rare, but healthcare providers should be aware of the potential risks and carefully weigh the benefits versus the risks when selecting and monitoring anti-VEGF therapy for DME. The prognosis for DME largely depends on several factors, including baseline visual acuity, central macular thickness, and response to treatment. Long-term management involves a combination of regular monitoring, maintenance therapy, and lifestyle modifications, such as glycemic control and blood pressure management. Collaborative and patient-centered care is crucial to optimize treatment outcomes and maintain visual stability over the long term. Combination therapies, such as combining anti-VEGF agents with corticosteroids or laser photocoagulation, have been explored in DME management. These strategies aim to target multiple pathways involved in DME pathogenesis, potentially enhancing treatment efficacy and reducing treatment burden. The selection of combination therapies should be individualized based on disease characteristics, treatment response, and safety considerations. Research efforts continue to explore novel therapeutic approaches for DME. Emerging therapies include sustained-release drug delivery systems, gene therapy, and novel anti-inflammatory agents that target non-VEGF pathways. These advancements hold promise for improved treatment outcomes, reduced treatment burden, and better long-term management of DME. In conclusion, the management of diabetic macular edema requires a comprehensive understanding of its pathophysiology, accurate diagnostic modalities, and evidence-based treatment options. Anti-VEGF agents have revolutionized the management of DME by targeting the underlying mechanisms driving the disease. However, optimizing treatment outcomes necessitates careful monitoring, individualized therapy selection, and long-term management strategies. Ongoing research and development efforts hold promise for further advancements in DME management, improving patient outcomes and quality of life.